So I think to improve decision making related to financing, you need transparency and you need access to data, and that can be one of the biggest challenges that we face. Not having any oversight of the how budgets are implemented.
Hello and welcome. This is Rethinking Rural Health Financing. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo. Together, we are uncovering the stories, challenges, and innovation that is shaping healthcare in overlooked communities. In this series, we ask hard questions about how money moves, who gets funded, who gets saved, and who gets excluded. From policy to practice, we explore what healthcare financing should look like for everyone. When we talk about innovation or innovative mechanisms for health financing, especially for hard to reach communities and low resource settings, the conversation quickly drifts towards projects such as pilot programs, short-term grants, or external funding initiatives that promises quick wins. And while those efforts can play an important role in responding to the immediate health needs of the communities, this way of framing innovation can also be misleading. Sometimes it distracts us from thinking more deeply about the foundational approach to healthcare delivery. True innovation in health financing is really about building strong, nationally led health system that can be financed from within and sustained over time. Because without a solid national financing backbone, even the most creative project will struggle to last. A resilient health system is not only one with better infrastructure, but one where resources are deliberately directed through national budgets, where governments have physical space and autonomy to plan, allocate, and respond to their own health priorities, and where communities are not just treated as beneficiaries, but as active participants in shaping how health resources are used. My guest today will be helping us unpack this in more details, particularly how system level financing can strengthen service delivery in practical ways. We will be exploring how stronger national health financing system can give government, local health leaders, and community the flexibility to respond to local needs in real time, invest in what matters most to the people, and ultimately build health resilience that is empowering, locally driven, and sustainable over a long period of time. But before we dive into all of this conversation, let us take a quick break.
If you're enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. Please like, leave a comment, share, and most importantly, give us a review. It helps others discover this important conversation.
All right, back to the episode. You are listening to the podcast that asks critical questions with Chinasa Imo. So now let me introduce you to my guest. My guest is Sarah Fox. She is a health system and financing expert with more than 20 years experience designing and strengthening reproductive health and family planning programs across low and middle income countries. Her work focuses particularly on sustainability through improved governance, accountability, and equitable use of public resources. She's a recognized technical thought leader on health financing, a member of the High Impact Practices for Family Planning Technical Advisory Group, and she contributes to global effort on diversifying financing for reproductive health supplies. What makes Sarah especially relevant for today's conversation is her experience in helping countries move beyond donor dependency towards stronger national financing systems that support universal health coverage. Thank you so much, Sarah, for joining me today in the studio. Welcome to What About Rural Health?
Thank you so much, Chinasa. It's such a pleasure to be here and an honor to be invited as a guest alongside all of your other esteemed guests that you've had on so far. So I'm really delighted to be here and happy to be having this conversation around this really important subject.
Thank you so much for joining me. And for our listeners, I just want to preface the fact that Sarah used to be my former colleague when I was working in Nigeria for options. And I'm happy that she came to the studio to have this health financing conversation. Sarah, the thing is that prior to the new trend of, diminishing resources that we are seeing now globally around health financing, there's been a tapered signal around the fact that donors are no more interested in some way in putting so much money in piloted program. And sincerely, I've had a lot of conversation from people in Global South, and they keep thinking that this keeps them in a dependency mode instead of active planners of their health resources. And now we are here talking about this topic, how we should begin to rethink around health financing, but not just about how money moves, but also what are other ways that we can sustainably ensure that resources are adequately structured in ways that are sustainable. And that brings us to a whole lot of conversation about innovation in health financing. And I know that this conversation, whenever we hear the word innovative financial mechanism, people think, oh, let's go do projects, right? And these projects are short-term initiatives that we've seen over time. They are good, like I'd said before. They have saved enormous life, but they all have timelines and they all exist at some point. So from your experience working across different countries, what does this framing miss, especially when we think about financing for rural health facilities and communities?
Thanks, Chinasa. And just to say, I really agree with the framing that you set up for this conversation. As you said, I'm a systems person, so I really believe in the importance on investing in health systems to ensure sustainability and resilience over time. But the reality is countries are facing real challenges right now when it comes to health financing. As you said, the overseas development assistance and particularly ODA for health has dramatically declined. And at the same time, domestic countries are facing shrinking fiscal space with the debt servicing costs spiraling and other economic shocks that they're facing. So it's a real challenge, and it's understandable that people are looking for innovative and new solutions to fill these gaps. But really, I would say that the biggest potential lies in the investing in the health system to build more resilience, to ensure equitable and sustainable health outcomes.
Thank you. Thank you for that response. And yeah, I agree with you. It's time for countries to begin to figure out how do we get our people healthy, right? So when you, in your work, look across all of these health systems that you've worked in, what pattern do you see in how rural health services, but more broadly, how health services has actually is being financed today? Like we want to paint a clear picture, at least for our audience listening and learning, on what is obtainable right now and where these systems tend to struggle the most.
So globally, there is a broad recognition that primary health care is the cornerstone of achieving universal health coverage. That is not disputed. But sadly, the reality is the majority of funding is not being allocated towards the primary health level, which means that access to services and supplies is extremely inequitable, and there is an over-reliance on out-of-pocket payments. So countries like your country in Nigeria, over 40% of total funding for healthcare comes from out of pocket, which is obviously hugely inequitable and exposes families in rural communities to catastrophic payments. You also mentioned the over-reliance on donor funding, which has propped up primary healthcare service delivery, particularly in kind of priority areas such as HIV and reproductive health. And, that is, as we know, is not sustainable. So, whilst that acknowledgement is there that primary healthcare needs to be prioritized, we're not seeing that prioritization being translated into resources, on the ground.
Yeah, I like the fact that you raised the conversation around where this bulk of money come from and the mindset that structures the system. Because when I look at, for instance, donor funding, it does have metrics, and most of the metrics are targeted at specific indicators, right? And truthfully, those indicators, like I would always say, I recognize what those interventions do because you cannot track everything. And if you're a project-driven intervention, there is something that should show us an indicator that something is working, right? Which is the whole essence. You need to implement, show the donor that something is working for them to give you more money to expand, scale, or to move to a different direction. And I also recognize the fact that these things have a spiraling effect, like it goes to impact other things. Like when we talk about HIV funding, right? There is the preventative part, and within that, the outreaches would get to thinking about other determinants of HIV. However, where I often disagree and I have some kind of reservation is that when we talk about primary healthcare, it sounds so basic. Like primary healthcare is supposed to just be about whether we're doing maternal newborn health or we are doing HIV or we're doing malaria for affected countries, etc. But we've come to see that the fact that it's called primary healthcare and it's closer to the people in rural doesn't mean they don't have special needs. Like dementia is still a problem of the rural people. Cancer still happen to rural people, and other forms of communicable and non-communicable diseases. And the one that is even more obvious is that 70% of public health emergencies are zoologically linked, which means they come from rural environment most of the time. Yet, when we budget is for primary health care is usually this basic, meaning that we miss a chunk of our health security infrastructure that is resident in rural care. But I mean, that's a little bit, but I'm just putting my displeasure to why I think that, and I agree with you that external funding are not sustainable and they are not equitable because they don't spread resources across country-specific priorities. If you know how outbreak comes from, say, the eastern part of Nigeria, should you not put a whole lot of money into making sure that you respond effectively and have like an integrated model that addresses primary health care, but also from an emergency perspective? And this leads me actually to the next question that I wanted to ask you. And building on all of this, what does it now mean from your own perspective? I have registered my displeasure, but from your own perspective, what does it really mean to innovate within national health system, not just around it, if the goal is to sustainably fund rural health facilities and support communities?
So, I mean, this is a huge question that we could talk for this whole hour on, but I think for me, it's about thinking about what are the bottlenecks within the health system, and really understanding those and addressing those so that by building those, building that infrastructure and those systems that you can then achieve results over time. So some of those systems include the public financial management system. So that could mean improving how plans and budgets are developed right from the facility to the subnational to the national level, and therefore reducing duplication and fragmentation, as well as improving execution rates of budget. I think on average in low-income countries, 13% of budgets are not spent. And when you consider that most of health budgets are going to salaries, that means a very significant chunk of the recurrent expenditure remains not spent within budget. So there's huge scope there to kind of leverage more resources for healthcare if those budgets are actually spent. And another health system that we can look at to increase resources is the supply chain system, ensuring that that is functioning effectively and that supplies are being channeled through the system and reaching the last mile. We know another, on average, 20 to 40% of resources within health systems in low and middle income countries are wasted or are inefficiently used. So there's really huge scope there to kind of spend smarter and do better with resources that are available. As I said, doing that through systems. There's also the information system, so ensuring that the different information systems, whether it be the health management information systems and the financial management information systems and the logistics management and information systems, that these are functioning effectively, that they speak to each other, that they produce data that is then tracked for accountability purposes. It's really about achieving those efficiencies and effectiveness through the existing national systems.
I absolutely agree on, the way that we should strengthen systems. But I like the particular word that you use, making sure that they speak to themselves. Because I think we can talk about money all we like. If there's no clear structure on how these systems actually work, they begin to burden each other, meaning that the DHS system is going to be have a huge burden on the financing system because they're not speaking to each other. So thank you very much for raising that point. To our listeners, when we talk about project-based funding, I just want us to be on the same wavelength. When we talk about project-based funding, we usually mean time-bound initiatives, such as funding that starts, runs, and ends, and is often driven by external priorities. System-based financing, on the other hand, is about how money flows through national budget, public financial management system, and local health structure in a way that lasts beyond any single project. So for rural communities, the difference is critical. Project can fill gaps temporarily, which we've established here very clearly. But strong national financing systems are what allows facilities to stay open and for staffs to get paid, for medicine to continue to remain in your shelves, and for communities to trust the care, and that the care will continue to remain when they come tomorrow after tomorrow. So as you think about your own countries and communities, how does innovative health financing show up where you are? Do you feel it helps build strong autonomy, resilience, and accountability within your health system? Please drop us a comment on this episode. Thank you very much. So coming back to you, Sarah, now let's discuss in practical terms, because this is where innovative financing can either strengthen health system or complicate things. So when we talk about nationally led financing mechanism within health systems or even at the infrastructural level, how does this work? Because that's where I like to start. Like in very simple time, how does it work? How does or should countries move funds from their national treasury down to local government or to rural facilities, and what tends to influence how effective this happens?
So, in many countries across Africa and other low and middle income countries, there's been a shift towards fiscal decentralization, and we all know what that's really about: moving government closer to the people. And what's meant to happen is that responsibilities for planning and budgeting are devolved to a subnational or even facility level, and that they have some authority over spending. In reality, however, this doesn't always happen as planned, and there are a number of challenges in actually kind of fulfilling this goal. So we've got issues around overlapping roles and responsibilities between the different levels of government. There's weak accountability, and also we know there's political interference. So where the best laid plans are in place, it depends on who are the real decision makers within the system, and so the kind of how that works in practice is very different depending on the context, and a lot of it depends where the country is in this decentralization journey.
Mm. Mm. Decentralization. That's a big that's a big statement. Can you, for the purpose of my audience, explain a little bit what do you mean by decentralization?
Sure. So, in a very centralized context, decisions are made at the national level, and plans are made. Prioritization happens at the national level, and resources are generated nationally and then allocated nationally, and each using an allocation formula, each subnational level will be given resources, but the authority and responsibility for decision making rest within the central level. In the move towards decentralization, the idea is that government is getting closer to people, so that the specific needs and the prioritization reflects the needs of communities, the disease burden in different geographic areas, and so it really reflects the realities on the ground, which obviously, as an ambition, is very laudable. It's just that the realities of achieving that are can be quite challenging. The other kind of complexity are in countries like Nigeria, where you have a federal system, so it's kind of a stronger level of decentralization, where states are given, they have higher levels of autonomy to manage and generate resources within the state, allocate and manage the resources that they have within their geographic area, with the federal level mainly being responsible for kind of policy. And then you have other countries which are much less centralized or decentralized, than that.
Thank you so much for that explanation. I know I have read an article somewhere, that's criticizing centralization, decentralization, and then introduces the third part of re-centralization. Instead of top-down centralization approach, you come from down up, but it's like not really centralized, but gathering evidence from lower level and still bringing them to a central system. And all of these things, I don't know which model works better. And I guess is something that countries need to actually sit down and do an assessment of how do we make this system better, right? But I agree, it's for a country like Nigeria with, very heterogeneous demographic and geographical setting, that decentralization work. But I'm just kind of like moving a little bit further on this conversation. One thing that have also been a large conversation is the responsibility system where the federal government have certain exclusive right. There are certain rights that they concurrently share with the state. And then there is also the question of local government where primary health care reside mostly. Yet the local government structure, governance structure itself, up until recently, does not really enjoy certain level of autonomy. But let's hold that there because we have a place where we would have this conversation. I just wanted us to introduce that so that it would dovetail very well. So going back to what you responded to me earlier, I wanted to ask you, are there signals that we should pay attention or that when we see, it will really tell us that a nationally driven financing approach is actually working? It's not just improving reporting systems or creating more administrative burden?
I think we all believe in the importance of decisions being nationally led and kind of nationally owned. So for me, the progress can be shown where initiatives are really embedded within existing structures and processes rather than being implemented in parallel. So things that we have seen are where we have implemented reforms like budget tracking exercises that help to increase budget execution, as I mentioned, and having those owned and implemented routinely by existing mechanisms, whether that be a technical working group or a national or subnational committee. And so where those initiatives that have been introduced, perhaps through a project, but then become self-sustaining and functioning independently, I think for me that's a success story.
Oh, okay. Okay, thank you. And I know that you mentioned data the other time when you started, but where do you think data fits into all of these things, and how can or how do countries use data better to meaningfully improve financing decisions?
So I think to improve decision making related to financing, you need transparency and you need access to data, and that can be one of the biggest challenges that we face of not having any oversight of the how budgets are implemented. And without access to that data, it's very difficult to have a meaningful accountability function. I think it's also data is so critical when it comes to prioritization of resources. So no matter where a country sits within in terms of resource availability, there will always be a need to prioritize scarce resources. And there are so many competing priorities. So without accurate and up-to-date data around disease burden and around on one hand, and also around demographic changes, and also in terms of effectiveness and cost effectiveness of different interventions, it's impossible to really make those prioritization processes effective.
Thank you so much. Let's go for a quick break.
Do you want to help drive rural health forward? We're looking for passionate volunteers to support our work, from research to storytelling to business outreaches. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up.
Welcome back. You are still listening to What About Rural Health with Chinasa. So, Sarah, one issue that keeps coming up in rural health is facility autonomy. Coming back to the conversation that we paused earlier on, communities want health facilities that are tailored to their needs, facilities that are culturally responsive and sensitive to local health determinants. But for what that means is that those facilities need certain level of autonomy to make decisions on the ground. including the government, the local governments that have an oversight function on how these facilities run. So from your experience, how important it is for frontline facilities to have this control over the resources and what kind of decisions that are realistically made to empower this process?
Well, I mean, as I touched on, to deliver on the ambitions of decentralization and really fulfill the aspiration of a primary health centered approach, health facilities need to have authority over how resources are prioritized and how they are spent. And what this means in practice is, having meaningful participation in planning and budgeting processes, as well as authority once those budgets are approved, that they have authority to spend against those. There are a number of challenges that kind of, you talked about re-centralization. I think that can happen where there are concerns around financial mismanagement and potential corruption. If there aren't kind of good oversight systems in place, or the accountability isn't there, which kind of push against that intention to give that autonomy. So there's those kind of competing forces, but really, to achieve those ambitions of primary health care outcomes, that there needs to be some level of autonomy, and we see that across very different contexts facing similar challenges. Recently in Kenya, we've been supporting county governments. So Kenya has been decentralized on a decentralization process since 2012. And that is one country where that there was this talk of re-centralization, because according to the Public Financial Management Act, facilities were supposed to have autonomy over the use of the resources that they generated. But how that happened wasn't clear, and it was left to kind of counties to figure that out. And so a couple of years ago, the government passed a Facility Improvement Fund Act, which outlined how that facilities should have autonomy over the use of those resources that they generate locally. And so we were supporting that process in various counties in Kenya. Similarly, in Madagascar recently, we've been doing some support to the basic health center level, where it wasn't clear, the process again was not clear over, the intention was of basic health centers to have autonomy over their resources, but the process through which they would be able to access funding from the kind of commune level was not clearly articulated or understood. And so we've been supporting that process to clarify how that can happen. And so I think the intention is often there, but the devil is in the detail and in the kind of the operationalization of those in kind of policies or intentions is really, what matters.
I thank you for sharing that. I absolutely agree with you. One thing that came out of your explanation that I want us to push a little bit forward more is this conversation of having autonomy versus actually knowing what to do with this autonomy. And this is where I praise development experts in providing technical support. Like, I don't entirely say, oh, development work, isn't beneficial. That's never been the conversation. But how do we mainstream this technical support in a way that helps local governments strengthen their system? And what you are explaining to me right now is we did not come with our own initiative just because we have donor funding. The government made a state policy, but on the ground, this thing requires people to somewhat, in some way, guide expertise on how this autonomy can be, claimed, can be utilized, and can be sustained. And please share such a story to me. Walk us through how this process worked from, this is a policy that's been nationally driven, and now the counties. So for our listeners, some countries go by counties, some go by local government, and some go by districts. So just know all of these things means locally driven government or governance. So can you please share us a story of where we've moved from having these national policies to bringing it down to making it actually work?
So maybe going back to Kenya, a number of years ago, the government announced a Linda Mama initiative, which was a free health services for free maternal health services for pregnant women. And this was it was a national initiative and, broadly spoken about nationally. But again, this issue of operationalization of it was not clear. It wasn't clear to health workers in terms of how they were meant to access or being reimbursed for the services delivered through the scheme. It wasn't clear to communities in terms of how what were their entitlements, and so we worked in one county in Western Kenya to really engage with healthcare providers as well as community health workers to address those two challenges. So we engaged with health facilities to train them on exactly what the package of services was, how they should be able to seek reimbursement and make claims through the system using mobile money to access that funding. And to kind of all of the administrative processes that they needed to be able to access that funding. At the same time, we engage with community health workers to inform and educate communities about what they were entitled to, because that's often a huge barrier to access, is that people don't know what they are entitled to. We had a similar issue in Nigeria, where there's the basic healthcare provision fund and the challenges that people didn't actually know what was in it, and so they don't demand services from the health facilities because they aren't clear about what those services that they are entitled to by law to access. So through those two initiatives, we were able to increase uptake of those free healthcare services for maternal health. I think that county then became one of the front runners in terms of awareness and access to maternal health services. So yeah, it's an example of how an excellent policy doesn't really mean anything until it gets operationalized. And there are so many challenges and so many different actors that need to be engaged in order to support the operationalization of the policy.
Thank you so much. I love the stories that you share. And I think that when you mentioned the basic healthcare provision in Nigeria, I resonate with that because I remember when we began talking about this domestication of the basic healthcare provision fund at state level, even some directors at the ministry did not even understand, like, what does this distribution gateway means. And I think this is high level conversation. I don't need to explain it to our audience, just understand it that way. But the fund has different funding gateways, right? And they are within those gateways, there are ways to draw funding out of it. But if the people who are supposed to oversee the distribution of these funding gateways don't even understand, how this money get released, how then will facilities know what to draw from? And that had become a whole conversation. But something that you said, and this is also where the Basic Healthcare Provision Fund in Nigeria continue to suffer, is citizens' awareness and engagement. And that is the other part of autonomy and accountability, because these two things has to work together. It's one thing for government to give you the autonomy to make decisions and use your money, but it's another thing to be aware and then know how to be accountable for all of these things and how you drive the demand for XYZ. So when you look through where you have worked in, And you have stated clearly, you keep bringing in that conversation about communities. So in practice, how can communities be meaningfully engaged in shaping all of these health financing decisions and not just be people that we go to consult, temporarily, but they should be in the like that's how I feel they should be in the day-to-day um influencing of the priorities that serve their health need if they wanted to also be culturally attuned.
Yeah, I mean, it's a huge issue. I think it is one that is widely recognized. So if we think about kind of principles of public financial management, public participation is widely recognized as a key dimension that must be realized in all contexts. Again, the issue is how does this happen in reality, and how do you meaningfully engage citizens? Um, it's very easy for someone to invite someone along to a meeting that they don't participate in, that they aren't informed about. That's not meaningful participation. And so the important piece is around establishing forums in which communities, civil society, and specific marginalized groups have the opportunity to participate and actively contribute to discussions and decision making, and have their voice heard. Um, as I said, this is challenging. It requires resources. It means investment in the skills of those participants so that they understand how to contribute meaningfully, that the barriers to their participation are addressed, that their voices are respected and heard, that the right people are invited in the room. It can't be just kind of selected from people's direct kind of contacts, but it has to be people who really are in a position to sort of speak on behalf of their constituencies, whether that's young people, people living with disabilities, women, and different groups within the community. In terms of effective accountability mechanisms, many countries have some version of either community development committees or facility management committees. And these are really important structures to support community voice in the decision making over how primary health care resources are prioritized and used. So they should feed into what the main needs of the community are, and what should be prioritized in terms of resource allocation. And they should also have oversight about how those funds are spent, and whether they're spent well, whether they are being translated into quality services and meeting the needs of the community. It's a challenging one though, because it's expensive. Investing in bringing all those people together takes funding.
I agree with you, and but one thing that have been echoing when we talk about community engagement and participation in decision making, a bucket of things have shown up within critics, of this model. And the obvious one is financial constraint. There is also the conversation about politics, local politics, and who drives what decision. And on the part of the participant, there's also the thing about expectations and commitment. But the biggest problem is, how do we juggle all of these things? I know it's obvious. You cannot expect the health system to serve you better if you don't create time. This is what I always answer. If you don't create time to advocate for yourself, I don't know what your healthcare needs are unless you explicitly tell me. And that conversation has to happen in a very conversational but informed process, where you actually know what you are telling me, versus, oh, I just feel sick, therefore So there's all of this conversation, and critics have latched onto these inefficiencies to question the efficacy of community-led participation. And then from facility level, people say, oh, community participation drags us backward because it slows down our ability to make quick and efficient decisions. So what is your take in all of these issues that are raised around community-led initiatives?
Well, I'm a believer in the phrase, I'm sure you've heard this, but nothing for us without us. Of course, our criticisms and challenges around how these mechanisms are implemented, but that doesn't negate their value. That just means that the operationalization needs to be improved, and that we need to invest more in them. I really think they're absolutely critical. And going back to the issue of autonomy, facility autonomy, unless there is a strong accountability mechanism in place where the facility manager has some oversight and is being held accountable for decisions that are being made, that kind of level of autonomy can never really be realized. And so I think whilst the challenges are there, it doesn't mean that it's not the right approach. I do think that resources play a significant part. It's expensive to bring those people together in a meaningful way, and I stress the word meaningful because having people around a table won't achieve anything unless people are able to effectively contribute, and that requires investment. But I believe that it's critical to really improve that accountability at the local level.
I want to continue to re-echo the word investment that keeps showing up in all of this conversation. Investment in people skills, investment in health system, investment in structure and infrastructure, investment, meaning that in what I'm hearing is that we should move away from thinking about health and rural health, particularly, and primary health, particularly, as beneficiary-driven initiative, and start looking at it as core economic investment, because that's the word, that's like the real word that is coming. But before we continue this, let's take a quick break. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from research to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. Welcome back. You are still listening to What About Rural Health with Chinasa. Okay, so now let's move ahead and look forward. We've discussed the issues, we've talked about the problems, we've looked at different mechanisms. So let's look forward. What should we do? Many health programs, such as the family planning, maternal newborn health, reproductive health rights, still rely heavily on project-based funding, which I think that we've made obvious. But now we are looking, how do we shift from this towards a sustainable financing program, and what does that require?
So I think that the number one answer to this is political will. If there is political will from the top down to the local level to drive change, that is the single kind of most important way of making progress. Within family planning and reproductive health, many governments have signed up to a number of commitments, whether that be FP 2030 commitments around increasing the modern contraceptive prevalence rate or increasing investment in family planning, as well as the Sustainable Development Goals around universal health coverage. Those commitments are there, but it's really about how are those being translated, and are decision makers really taking seriously the need to invest in these services. From the health sector perspective, we can support this by presenting the investment case to the Ministry of Finance. And you know, for in terms of family planning, that's an easy investment case to put forward, because it is clearly a best buy. It's the returns on investment are huge. We have the data. It contributes to human capital development through labor force participation, through educational outcomes, and it is also cost saving, because you reduce the cost of reproductive and newborn health services by investing in family planning. So the investment case is clear. It's about presenting that to ministries of finance and really ensuring that these services get prioritized within the health envelope that's there.
Thank you. But now I want us to be particular about this approach, especially one that works through national systems. What is the one real particular approach that you would say holds real promise for rural health, and what would make that model work well?
Well, one that comes to mind, and it would be interesting to get your thoughts on this, but I was really impressed and just felt very positive about the progress that's been made in Nigeria around the sector-wide approach, and this the leadership that's been shown in Nigeria around this one plan, one budget, that has encouraged donors to all align around a nationally led plan from federal level down to the state level. And this has huge potential to reduce fragmentation, improve accountability, and accelerate progress towards UHC with a primary health kind of care focus at the center. And so, the needs are huge in Nigeria, and I think that there seems to be a real momentum, people galvanizing around this agenda, and kind of going back to that political leadership. It really is being led by the Federal Minister of Health, as well as other key leaders within the health sector, and so that's, I think, one exciting initiative that I think shows huge promise. I think with
Go ahead. Sure.
No, I was going to talk about something else. So
no, go ahead. I will come in later.
Okay. Another initiative that's across multiple countries is a matched fund arrangement that UNFPA have initiated. I think it's been in place a couple of years now, and they currently have these matched fund arrangements across 31 countries, whereby, based on a number of criteria, they have pledged to provide $2 for every $1 that national governments invest in reproductive health supplies. And that initiative seems to be showing success in terms of catalyzing domestic investment in reproductive health supplies. Because that funding can only be leveraged through that commitment. And it's seeing countries like the DRC has recently pledged $5 million annual investment in contraceptive commodities over the next 5 years from a baseline of zero. So it is showing promise in terms of unlocking domestic financing for reproductive health.
Thank you so much for sharing these two models. I will start from the last one. I just want to ask a quick question and then come back to talk about the One Health approach. I love the matching grant because it triggers national economy to start on something, right? But when we look at retention and expansion, is there, and this is me being curious, is there a process that at some point, say after 2 cycles of matching your country, is there like a taper away process where this funding gets to, from UNFPA, gets to taper down, and then the commitment from countries get to push forward, say from $2 versus 1 to 1.5, 1.5 to flipping around for countries to put in $2 and UNFPA to put in $1 until we draw out the entire funding and now see how countries get to 100% lead on this process, because then that is what I would see as a sustainable way of building infrastructure.
I think that's a good question. To my knowledge, the current UNFPA model doesn't include that sort of tapered reduction in the ratio. And, we are in this very particular context right now where there's been a dramatic reduction in investment in contraceptive commodities through the closure of USAID. So right now it's about trying to get as much resources and fill this huge gap that's been opened up. That said, in Kenya, going back to Kenya, we did support such an arrangement that was it was a kind of a pooled fund. So it was with FCDO, Gates funding, and other donors were investing, and it was precisely that. It was the government of Kenya committed to take on a greater proportion sequentially each year, whilst the donors would reduce, and it was and that kind of a memorandum of understanding was agreed and implemented. So I think there are models where that has been undertaken, and yes, certainly where that's feasible, where the fiscal space allows, that's certainly something that should be pursued. I think one lesson from these models, both from the UNFPA match funding and that example in Kenya, is the importance of setting expectations across sectors. So making sure that the Ministry of Finance and the Ministry of Health and donors are sitting around a table, and that they're all signing up to the same strategic objectives and understand what expectations are. I think sometimes these conversations can tend to happen more with Ministry of Health, and then they don't get as much traction unless Ministry of Finance is firmly kind of involved in the whole process.
Thank you so much for explaining that. And coming back to One Health approach, I do like that One Health approach because it doesn't just... So when we look at the social determinants of health and understand that health is not just the point of service delivery where people walk into the hospital, right? They are, in fact, the determinant has been expanded to include transportation, environmental issues and all whatnot. And Nigeria looked at all of these things and said, let's have a One Health approach that brings together the allied health services into one bucket and work through that to look broadly on what affects and influences health, right? Now, to the extent that this is actively and functionally working is what I am not opportune, I'm not privileged to speak to that, but that is one model that I have been rooting for since my early year as a master's student trying to study development health policy. And I came across this One Health approach. It's been one thing that I recommend as this is the best approach to go if only is nationally driven and people actually take it seriously. So thank you for bringing that up. And I must say kudos to any country plus Nigeria that have, started this process. When we talk about sustainable health financing, it doesn't happen a day, but it is the intentional process by which we take on and keep expanding and keep institutionalizing that gets us to where we need to say we've built enough resilience to stand on our own. So, Sarah, as we wrap up, I just wanted to ask you one last question that I ask my audience. If you stand in front of the Minister of Health in Kenya or in Ethiopia, and you are telling this person everything about rethinking health financing, what is one thing you would tell them not to do?
First of all, my first response to that is I wouldn't tell them what to do at all, because I think things should be led by the minister, and I very much believe in that. I think it's maybe going back to this kind of national ownership. It's around setting the agenda, and making sure that government is in the driving seat, and not losing sight of that, so that the minister and all levels of government are really spearheading the priorities and ensuring that others are aligned behind them, and insisting that partners are channeling funding through government systems and aligning with national systems and processes. So I think it is incumbent on the ministry to ensure that happens as much as it is to donors to avoid that sort of those parallel structures.
Thank you so much, Sarah, for your time, your insight, and the important work that you continue to do around the world, strengthening health systems. To everyone listening, thank you for joining us on today's episode of What About Rural Health? If today's episode moved you, challenged you, or made you think a little differently, please follow us, subscribe, and leave us a review on your favorite podcast platform. And as always, let's keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo, and bye for now.